We are back from recess, members. Senator Hoffman to Senate File 379.
Thank you, Madam Chair and members. Wonderful to be back here. The 379, there was a Mr. Johnson from DHS. There was an amendment that should have been put in front of you guys. Do you have that? Yes or no? If you don't, it's no big deal. We can fix it later because it's just all it does is on line 2.25. After payments, we delete received by a non-exempt member of the assistance unit, and then the words after that stay. So that's just from technical assistance that was provided by Minnesota's State Department of Human Services. So if that's not in front of you, we can worry about it later, Madam Chair.
Senator Hoffman, we can do an oral amendment.
Mr. Johnson, do you want to come on up here and get the okay from the department if you're available, Madam Chair, if I may?
Go ahead.
Hello, Chair. Ryan Johnson, Minnesota Department of Human Services. I believe that Senator Hoffman got the oral amendment correct in terms of striking, I don't have the bill number in front of me, but striking the words received by a non-exempt member of the assistance unit from the language.
Madam Chair, Mr. Monahan is shaking his head yes.
Mr. Monahan.
Madam Chair, members, the motion would be page 2, line 25, delete received by a non-exempt member, and on line 26 to delete of the assistant unit.
Members, any question on the amendment? All those in favor of adopting the, of the oral amendment, signify by saying aye. Aye.
Aye.
All those opposed? The amendment is adopted. Senator Hoffman, to your bill as amended.
Thank you, Madam Chair and members. Now this is in the final authority that we want. The bill eliminates a work disincentive for low-income people with disabilities who receive Minnesota Family Investment Program, otherwise known as MFIP, and work their way from SSI to RSDI. If you want me to do a historical reference on MFIP and how 20 years ago, no, I will just keep going. If a person in an MFIP family receives Social Security income, the person receiving the Social Security income is excluded from the Minnesota Family Investment Program household. In a 5-person household with one person getting SSI, the SSI recipient is excluded from the MFIP grant, and the household receives a 4-person MFIP grant. If a disabled, I wish this would be person language, if a person with a disability in an MFIP family works and earns their way onto RSDI, the RSDI is counted against the MFIP grant dollar for dollar. Most households do not qualify for any MFIP if there is RSDI. And so who is with me is Ellen Smart, who's a benefits attorney at Mid-Minnesota Legal Aid. So, Madam Chair.
Ms. Smart, please introduce yourself and proceed.
Good evening, Madam Chair and committee members. My name is Ellen Smart. I've been a benefits attorney at Legal Aid for 22 years, and this is my first session as a legislative advocate with Legal Aid's Legal Services Advocacy Project, and this is my first Senate testimony. Thank you for allowing me to speak today in support of Senate File 379. And thank you to Senator Hoffman for bringing this bill and Senators Abler and Gustafson for co-authoring. This bill is near and dear to me because the person who brought this issue to my attention is my client, Yoshida, who I met in 2021. Just so we're clear, SSI is supplemental security income. It's what people who have not worked enough to pay into the system receive when they become disabled, and it's usually because they've been disabled since birth or from such a young age they never were able to build up their work credits. RSDI is Retirement Survivors Disability Insurance, usually requires about 10 years of work, and then your benefit is based on past earnings. So this year, SSI is a flat fee of $914 a month, and RSDI starts at $934 a month. It goes up. So I want to tell you about my client Yoshida to put kind of a face on this. Yoshida graduated from high school and really wanted to go to college. She was getting a ride home from work when she was shot in the head by a bullet intended for someone else on the street. She had a very lengthy hospital stay, tons of therapy, and she started receiving SSI because she has a traumatic brain injury, and she has a host of issues, including recurring severe depressive spells and difficulty learning new skills. She got married, had 4 children, and divorced her husband after years of abuse. Child support has been sporadic at best, and she started receiving MFIP for her children. For years, Yoshida received SSI and her children received MFIP. In 2021, when Yoshida contacted legal aid, her family income was $1,515 per month. So that was $794, which was the SSI standard at the time, and her children received $721 in MFIP. She said that we were far from rich, but we had food, they had affordable housing through the Section 8 project, and every Friday they did something special, like watched a movie and had special snacks. Yoshida believes strongly in working if you can and wanted to demonstrate for her children. So she got jobs. She doesn't have a hard time getting them. She has a hard time maintaining them. The demands become overwhelming. She can't keep up because it's hard to retain information, or she falls into a depressive spell. But even with all these challenges, she managed to work her way onto RSDI eventually. But this is where things went wrong for her. Because, as Senator Hoffman said, RSDI counts dollar for dollar against the MFIP grant. So she was getting $1,515 a month while she was receiving SSI. Once she started getting RSDI, her income dropped to $838 per month. Because she worked, she and her children experienced food insecurity for the first time and had to start using food shelves. Also, because she worked, she fell behind with her utilities and was threatened with shutoffs. And then that could have spiraled them into homelessness, because once you have utility shutoffs, you can lose your Section 8 voucher. We were lucky enough to get her on energy assistance pretty quickly. So what this bill would do is treat the 2 Social Security programs similarly and remove that penalty for working. RSD would be regarded up to the SSI level, so that parents who are working and families who are working would not be put in a worse situation than they were before they earned their way onto RSDI. Well, thank you very much for your time today, and I really appreciate the opportunity to testify.
Thank you so much, Ms. Smart. And your first time testifying was significantly better than mine ever was. So congratulations. Members' questions?
Thank you.
Seeing none. Senator Hoffman, we will be laying over 379 for possible inclusion. Or unless you had any final comments, good sir.
No, Madam Chair, I am just, this is one of these things that, you know, it's affecting 95 families, but it is discrimination on the fact of, and it's nice to see a fix to the system, because once again, you know, the people with disabilities just have to keep proving, and it just, I mean, from our committee that you heard this afternoon to now, this is really a good bill, and I appreciate the support here. Thank you, Madam Chair and members.
It's a wonderful bill, and I'm mad that it's full, so.
Thank you.
Senator Hoffman, Senate File 2145.
Thank you, Madam Chair and members. This is the Senate File 2145. And with me is Dana Bacon. Dana is with the Leukemia and Lymphoma Society. Man, it's a word I can't, look at that. It must be late. So how are you, man? Thank you for being here. And Madam Chair and members, this bill promotes quality and access to the care that we have, palliative care. In Minnesota is a team-based medical care to manage pain, stress, and symptoms for people with serious or life-limiting illnesses and to support caregivers. It helps at any age and any stage of care, and it reduces the frequency and cost of acute medical events and increase patient and family quality of life. The advisory council that exists to advise us on ways to improve access to this care, unfortunately, the council's effectiveness has been hindered by a lack of state funding, and the council is set to expire in 2025. And so this bill does 3 things that are important for us to really think about. It eliminates the sunset date. It fully funds the council's work at, ready for this, $44,000 a year. By the way, did you know $1.825 billion of money that's sitting in the surplus should have been spent in human services, Madam Chair?
I've
And
heard that,
It
yeah.
launches, I thank you, it launches a one-time DHS study on the fiscal, medical, and social impacts that would create a care benefit for medical assistants in Minnesota Care enrollees at a cost of $150,000. So 24 state and national organizations have endorsed this file here. And with that, Dana Bacon is here to really take us home. So thank you, Madam Chair and members.
Mr. Bacon, please introduce yourself and proceed.
Thanks, Madam Chair and members. My name's Dana Bacon. I'm Senior Director of State Government Affairs for the Leukemia and Lymphoma Society. I think you have 10 bills after this one, so I'm not going to give you a drama. Thanks for hearing this bill. Thanks to Senator Hoffman for championing palliative care. It's a branch of medicine that relieves pain and stress for patients, for families. It improves quality of life and health outcomes. There's so much good to say about it. You have a copy of the letter that 23 organizations and my organization signed on behalf of this legislation. Without belaboring the letter's points, I'd like to add just a little bit of context to why we think this legislation is important. Our letter notes an ongoing gap in state funding that Senator Hoffman mentioned. In the last month, this funding gap prevented council members from applying for a significant private grant to improve palliative care access and quality in Minnesota. The grant required 2 state employees to sign on to the application, including one to be the liaison for the grant. The state's commitment and time would have been small, but because of the funding gap mentioned earlier, there wasn't a dedicated staff position guaranteed to support the council's grant application, so they had to pass. And fortunately, we can still do something to advance palliative care this session, and it's the bill right in front of you. We know palliative care helps patients and families, and the council's work continues to identify ways that a modest amount of state funding can make a big difference in this space. So with that, I just ask you to please include this in the omnibus package that you're preparing. Thank you.
Thank you, Mr. Bacon. Members, questions? Seeing none.
Madam Chair,
Senator Abler.
it's a good bill.
I do see some highlights on Senator Utke's notes there. No question? Okay.
I think, Madam Chair, we probably addressed the financial fiscal note thing, didn't we? I think we're good on that one, aren't we, Senator? Thumbs up from him, so.
Wonderful. So with that, we will lay over Senate File 2145. Thank you, Senator Hoffman.
Thank you, members. Thank you, Madam Chair. Thank you. Yeah, thank you. Thank you.
And now we will move to Senator Morrison is going to present Senate File 2444. Thank you. Senate File 2444, please go ahead and begin your presentation.
Thank you, Madam Chair. Madam Chair, members, thank you for the opportunity to present Senate File 2444, a bill to provide naloxone in our schools. Members, the opioid epidemic is accelerating. We lost more than 1,000 Minnesotans to overdose in 2021, 1,000 lives lost in a single year. The loss of every single one of these people is an unbearable tragedy for the families, friends, and communities that love them. If we're going to make progress and prevent more loss, we have to face some hard facts. Overdose deaths among adolescents increased 109% from 2019 to 2021, and deaths involving illicitly manufactured fentanyl increased 182%. Pills are easily purchased by teens who think of them as a safer option when they are using or experimenting. But the proliferation of counterfeit pills that contain illicit fentanyl and the ease of buying them through social media have increased the fatal overdose risk to adolescents. We simply cannot tolerate more needless loss of life. We have to act with urgency, and we have to act now. Luckily, we have an important tool in this fight. Naloxone saves lives. It is a simple, safe, and inexpensive life-saving tool that's easy to administer by nasal spray. It reverses the effects of opioids and stops overdose. It's not harmful even if given to someone who is not overdosing. It's not addictive. It doesn't get someone high or enable use. We need to ensure that naloxone is widely available and easily accessible so that lives can be saved. Ensuring that our schools have access to naloxone is critical so that no one dies by overdose at school. This bill is the brainchild of my constituent, Colleen Ronnie, who has made educating kids about opioids and preventing overdose deaths her life's mission after she lost her child to an overdose. She founded Change the Outcome, a nonprofit that aims to combat the substance use and overdose epidemic through educational initiatives for young people. Colleen has been in many schools, reaching thousands of young people through her tireless work to save lives. We've worked together over several years with advocates, MDE, MDH, school nurses, superintendents, and the Minnesota School Boards Association to craft a bill that will make naloxone available and accessible on school grounds. And we are continuing those conversations. Thank you, Madam Chair. And with that, I do have testifiers, I believe. I think that Ms. Ronnie is here.
Yes. Thank you, Senator Morrison. Yes, we have Colleen Ronnie and Tucker Robinson.
Should Tucker come up or wait?
And welcome to the committee. Please state your name for the record and begin your testimony.
Yes, thank you. My name is Colleen Ronnie. I am the founder and executive director of Change the Outcome. I'm also a parent who has lost a child to the opioid epidemic. Our son Luke was 20 years old when he experienced a fatal overdose in our home in 2016. His substance use disorder began in high school when he was prescribed opiates for his wisdom teeth. And then it just kind of spiraled from there. But I'm not alone. There are thousands of Minnesotans who have lost a child to opioids. I wouldn't wish it on my worst enemy. And having company, like all this company of all these other parents, does not bring me any comfort. It's what brings me here today. I've spent the years since our crushing loss presenting education about the opioid epidemic to middle and high school students and educators across the state of Minnesota with the extraordinary team, many of whom are behind me. We have traveled to all over. Many of them they're young people in recovery, or they're young people who have been impacted by a loved one who has struggled with substance use disorder. We're in classrooms every week, and we're seeing firsthand the precarious situation that almost every school is facing because of the absence of a simple tool that can save a life. The opioid epidemic has expanded and changed in many ways over the past decade. Few of those changes have been good. This public health crisis is growing worse every day, and due to the inclusion of fentanyl in the drug supply, it's taking a toll on young people at faster and greater rates than ever before. It's a common misperception, as Senator Morrison said, among young people that pills are a safer option when they are trying substances. 6 months ago, the DEA warned the public that 4 out of 10 pills, the counterfeit pills, contain a potentially lethal amount of fentanyl. Last month, that number jumped to 6 out of 10 pills. Pills are what young people tend to use. 53% of the students that Change the Outcome has presented to and have no idea what a counterfeit pill even is. They don't even know that they exist. So they can't possibly protect themselves against the risks that they come with. I think many of us have seen or read the news with increasing and alarming frequency of incidents across the country involving students overdosing, some fatally at their school. Last month, a New Jersey educator overdosed in his classroom. Sadly, overdoses are occurring in our schools. They have occurred in both middle schools and high schools in the state of Minnesota. Despite that, we have not taken the necessary steps to respond in a way that could prevent a tragic future fatality. Our schools are not required to have a simple life-saving tool, this nasal spray, despite the fact that we're in the midst of a fentanyl crisis, and overdoses are the leading cause of death for young people. the leading cause of death. We don't have a national epidemic of heart attacks, yet we require all public schools in Minnesota to have an operational AED on school grounds at all times. Additionally, all schools are required to train employees with appropriate life-saving skills like CPR and how to use an AED. It takes about 15 minutes to learn how to use this medication. The average cost of an AED is $2,000. The average cost of a single dose of naloxone is $23. Both have the ability to save someone's life. Closing our eyes to the most serious public health crisis our country has ever faced will not keep our children or loved ones safe. Ignoring the issue until someone loses a life is incredibly reckless. And honestly, if you lost a child to overdose, you would know that it's heartless to not have this in our schools. Schools are gathering places. In many Minnesota towns, they are the heart of the community. Schools are where tens of thousands of people spend a majority of their time every single day. It's only a matter of time before a life will be lost if we're not willing to embrace a solution that allows us to adequately respond should a child or adult overdose while at school. I've talked to hundreds of educators who care deeply about their students. Many have expressed a genuine fear that a student will overdose in their school or their classroom and they will be powerless to help. Several have asked what they can do to get their school to adopt a naloxone policy. Many have privately asked if we can leave them with a naloxone kit, even though they fear that if they ever had to use it, they would risk losing their jobs. We've been lucky so far in terms of not losing someone, but our luck is going to run out. We must require our schools to have Narcan in them or naloxone, and we must train staff how to use it. Lives depend on it. Thank you for this opportunity to testify.
Thank you very much for your testimony, and thank you for your work, and I'm very, very sorry for your loss and how you had to come to the work, but thank you very much for doing it.
It's really my honor. Thank you.
Mr. Robinson?
Sure. Good evening, Senators. Thank you for allowing us the opportunity to testify today. My name is Tucker Robinson, and I am the lead program facilitator at Change the Outcome. In this role, I've been afforded the opportunity to speak in numerous high schools across Minnesota about the opiate epidemic. However, I'm not just here to testify as a member of the Change the Outcome team. I'm also here to testify as a person in recovery. As of November of 2022, I had 5 years in recovery from opioid use disorder and substance use disorder. Given the nature of the bill that we're discussing, I'd like to offer some of my history of use and some trends in teenage drug use that I've noticed have changed, as well as ones that have stayed consistent. I started using drugs when I was 13 years old. Initially, it was just alcohol and marijuana. I was struggling with my mental health and issues at home at the time and felt like they provided me an escape. By the time I was 16, I had graduated to experimenting with several different substances, mostly pills like Adderall, Xanax, and Percocet. Over the next 2 years, much of this use took place on my high school campus. Teens today are still suffering from substance use disorder, opioid use disorder, and other co-occurring disorders. The teens that aren't dealing with these issues are likely to still experiment with drugs. Whether this is because they desire an escape, outlet, or they're just watching their friends do it and believe it to be safe, make no mistake, this is happening, and it's happening on school grounds. As for the things that have changed, the biggest one is the risk associated with using and experimenting with drugs. 10 years ago, while there was risk associated with using substances, it wasn't nearly as high as it is currently. Fentanyl being cut into street drugs and pressed pills hadn't become the wildly abundant issue that it is today. When I purchased a pill 10 years ago, I knew what I was getting. Now, pills and substances are marketed and sold as one thing while they are almost always laced, cut, or just entirely fentanyl. Whether people and teens realize it or not, the drugs they are buying usually contain fentanyl, and when they ingest these quote-unquote drugs, it's much more likely to cause an overdose. And because of this, these overdoses are happening everywhere: workplaces, parking lots, malls, our homes, even in our schools. As I said, I've had the pleasure of speaking in several high schools across Minnesota over the last 6 months. When I think of these experiences, there's one in particular that stands out. About 3 months ago, we were speaking at a school in the greater Twin Cities area. During our presentation, a student raised his hand and announced in front of the class and to us that he couldn't stop using drugs. That student was inconsolable. When the teacher and I went to step out into the hallway with him, we learned that he had left during the presentation to go to the bathroom and drink the better portion of a bottle of vodka. While we were able to get him to a safe place, I was left thinking about how it could have been just as easy for that student to go to the bathroom and take some pill rather than drink vodka and never have left that bathroom again because the school we were at didn't have Narcan on hand. It is essential that this bill be passed and Narcan be mandated at schools across the country and in Minnesota. There's no telling how many teen lives that it could potentially save. Personally, Narcan has both saved my life and the lives of many people that I know. Make no mistake, teens today are still suffering from substance use disorder. If they're not suffering from substance use disorder, they're likely to still experiment with drugs. Those drugs have a good chance of containing fentanyl in them, whether they know it or not, and that has a much higher chance of causing overdose. To mandate Narcan in schools would be a step in the right direction in both addressing the opiate epidemic and saving teen lives. Thank you.
Thank you for your testimony and thank you for your work. And now I show one more testifier, Kimberly Dunn Lewis. Welcome to the committee. Please state your name for the record and begin your testimony.
Thank you, Madam Chair. Good evening, Madam Chair and members. My name is Kimberly Dunn Lewis, and I'm with the Minnesota School Boards Association. I just want to say before I read prepared remarks, because that's what we do sometimes as lobbyists, that this is really hard. It's a very, very difficult subject and very heartfelt condolences to families and folks that have dealt with this. When we spoke initially, the question was, what do you think about Narcan? I said, I wish I never knew the name. I wish we didn't need it. So I just wanted to lead off with those remarks, but I appreciate the time that I have today to share thoughts with you on Senate File 2444. We have had many conversations over the years, and it's our desire to make sure that this bill can be executed with fidelity in our school districts, and I hope that we can continue the conversations. We are very grateful for the addition of funds that accompany with this bill. First, I'd like to share that MSBA has very recently collaborated with the Minnesota Department of Health to create an MSBA MASA, which is Minnesota School Boards Association and Minnesota Association of Superintendents model policy, and that's policy number 516.5. And it was created to assist schools that may have or are considering overdose medication availability. And MSBA has distributed that model policy to all our members, all 333 school boards across Minnesota within the last couple weeks. MSBA's model policy offers guidance and support for Minnesota schools that choose to obtain, administer, and store naloxone or Narcan, a medication designed to help reverse the effects of an opioid overdose in minutes. The Minnesota Department of Health is finalizing a web-based naloxone school toolkit. It will be an extensive resource that will include valuable information on opioid overdose, emergency response procedures in school settings, sample protocol and procedures, naloxone or Narcan information, resources for education and staff training, resources for staff, student, parent prevention and recovery, and referral resources, all very, very important in the whole scheme of things. MDH anticipates that this naloxone school kit will be available in mid-March. Senate File 2444 requires the person having control of the school building must ensure that at least one staff member trained on how and when to administer nasal naloxone is on site when the school building is open to students, staff, or the public, including during before school, after school, and weekend activities. Our concern is the bill's requirement presents an almost impossible standard for our schools because it requires at least one staff person on site when a school building is open to students, staff, or public. Districts would need to hire and train individuals for outside the regular school day. Outside the regular school day, our buildings are very often used by community members and community organizations that have no meaningful relationship with the school district. There are community ball teams, Boy Scouts, churches, for example, that use our buildings at night and on the weekends. Another approach to achieving the goal of the bill would be to have every school adopt and implement a written overdose or Narcan plan, which would include the identification of a school nurse or designated individuals at each school site who are on duty during the regular school day. We have other similar policies for seizure training or seizures, et cetera, that take place during the regular school day, we have a plan in place. And those individuals could administer or assist with the administration of the drug or medication to counteract the overdose. The plan should include training on the medications for employees the district identifies and the important ways to recognize the signs, symptoms of an overdose and appropriate steps to respond to it. The plan could also include what happens outside of the regular school day, before classes begin in the morning and after school and on the weekend, and reflect local decision about how to meet the requirements of the bill. Our model policy does include specific outlines for a district planning team who will oversee the general development and operations related to the use of the opiate antagonist. And we believe, again, that a local plan for during the regular school day is best. Outside of the school day, some schools may have an individual who is in the building at all times, but many do not. Once again, school districts could help develop a plan that may include workable options such as providing instructions to the individual or groups when activities are scheduled, or the medication could be placed in the AED station if there is one. I think there are ways we can certainly accomplish the goal, but to do so in a way that is workable in districts and school buildings by putting together locally developed action plans during the regular school day and outside of the school day, districts would be in a much better place to implement and control the intended purpose of protecting students from overdosing on narcotics. I thank you very much for your time and consideration.
Thank you for your testimony. Senator Morrison, any other comments right now?
Thank you, Madam Chair, and many thanks to the brave testifiers who I just am so grateful for their willingness to share their stories. And this is an ongoing conversation. We did have an amendment that we had hoped would be ready in time, but I think it's not. So I'm hoping that we would have the opportunity to add it at our next committee stop because we have to go back to education. But we do have some ideas. I'm thrilled to learn that the school boards have come up with a model plan. What do you call it? Model plan?
Model policy.
Excuse me, model policy for naloxone on schools because I think it's absolutely critical.
I agree. Yeah, I'm glad to hear that. Members, we will be passing this bill out to go back to education finance. Any questions? Senator Radke.
Thank you, Madam Chair. And a couple questions. We had the testifier that actually showed the product, like a vaporizer. Is that the only, I don't know how it comes, and I hear about it being handed out in various locations. Does that one comes, I guess, what do you want to call it, aerosol or vaporizer? Is there also an injected version? I mean, are there multiple ways to apply this or use the product?
Madam Chair.
Senator
Madam
Morrison.
Chair and Senator Uckey, yes, the more commonly and previously used is an intramuscular injection. The nasal naloxone is much less intimidating, I think, for most people to administer to someone, and it's coming, I think it's fair to say, in more frequent use. There's also news that naloxone may be soon available over the counter, which would resolve a lot of the challenges that we have right now. But you're right, there are different ways of administering it.
Senator Radke.
Thank you, Madam Chair. And just along the lines of the testifier from the school boards or the superintendents, and you're going to have continuing conversations, which is great because a couple questions came up. One, if there's any liability to the school by administering this, even though we heard that it's basically harmless if somebody gets it that doesn't need it. So that would be the one thing there, just wondering about the liability. And then if you're going to work on the fact, I know in my hometown, in the school, we have a huge room, the cafetorium, that gets rented out a lot for events, nights and weekends. And the fact that when the public is in there and there wouldn't be a school person close by, so that they would be able to do that and not be in violation of whatever this bill is going to say. So as long as those talks are continuing, and hopefully we can work around those things so that our buildings can continue to be used as they were sold to the public who help pay for these, and at the same time help protect our students who run into these problems. So thank you.
Senator Morrison?
Thank you, Madam Chair, and thank you for your comments, Senator Udke. I think that the liability question has been an ongoing part of our conversation, and we've been working carefully on the language to make sure that that is not an issue for the schools. And I think that Ms. Ronnie made a great point that schools are community gathering places, so it's important that that naloxone is there during those times as well. So finding a way to make sure that those buildings have naloxone is really important for both students, staff, and the community.
Thank you. Any other member questions or comments? Seeing no other comments, I just want to say I hope that you can make progress on this. I am glad to hear that there is a model policy developed, but I do think we should be going the next steps, because I think having a policy, I think we need to physically have access on site, and we need to figure out a way to make that possible. So I appreciate your bringing this forward. I also the language to add so that more people are authorized to be able to provide the naloxone. I think that's a good thing too. So anyway, thank you for bringing this forward. And members, well, the motion would be to recommend that Senate File 2444 be recommended to pass and be referred to the Committee on Education and Finance. Is that your motion, Senator Morrison?
That is my motion, Madam Chair.
Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail. The Senate File 2444 is passed and is referred to the Committee on Education and Finance.
Thank you, Madam Chair.
Senator Morrison, are you prepared to do additional bills, or do you have to get?
I need to grab a file, but sure.
If
want me to
you,
continue?
yeah, if you could do that, and then we could have you keep going. So the next bill of yours on the list would be Senate File 2339.
Madam Chair, this is a series of MDH policy bills, so I might ask MDH to join me at the table. But this first one, Senate File 2339, is very topical. This is the one that eases who is able to help prevent morbidity and mortality from opiate overdose. And the policy language change allows all nurses, school health professionals, and non-healthcare school professionals to respond to an opiate overdose emergency so long as the individual has training. And really, the idea is that by expanding the number of people who are able to administer it, we can save lives.
Thank you. And do you want to move your amendment, Senator Morris? Or I have an amendment here. Is that?
Thank you. Yes, I would like to move the A1 amendment.
Members, that's in your packet.
I missed that.
Senator Morrison moves the A1 amendment. All those in favor, please signify by saying aye.
Aye.
Any opposed? The amendment is adopted. So Senator Morrison, do you have further description, or did you want to turn to a testifier to provide additional testimony?
Madam Chair, yes, I would, or just maybe to respond to questions. Do you have, I think just to respond to questions.
Okay. Members, do you have any questions about the bill? I'm seeing no questions.
Madam Chair, everyone
It seems
agrees.
similar to it's kind of the part of the language is similar to what you were carrying in the other bill. I guess we'll have to work out if this moves forward and the other bill moves forward, we'll have to make sure the language gets coordinated or aligned. And, did they lay this over? I'm just checking. I want to make sure. I think the policy, all these policy bills, we are laying over. So if there are any questions, no questions, then Senate File 2339 is laid over for possible inclusion in another bill at a later date.
Thank you, Madam Chair.
Then the next one I have is 2341. Senator Morrison?
Thank you, Madam Chair. Madam Chair, Senate File 2341, it modifies cancer reporting provisions. I'll be brief, and then we'll turn it over to testifiers. But it's important to know that 4 in 10 Minnesotans will develop cancer over their lifetimes, and over 263,000 Minnesotans are cancer survivors. Minnesota is the only state that does not participate in the National Interstate Data Exchange, which is used to understand the impact of rare cancers or cancers within groups of patients, such as children and adolescents. Combining information on a regional or national level allows researchers to address health equity and disparities in high-risk, underserved communities such as American Indians, Asians, Hispanics, and African Americans. Because Minnesota is not able to share cancer information, we cannot participate in funding opportunities to improve the Minnesota Cancer Reporting System, Minnesota's system for collecting this data. So I think with that, I will turn it over to my testifiers, Madam Chair.
Senator Morrison, I do see an author's amendment, or an amendment is, it's a delete will and insert must. Is that?
I apologize, Madam Chair. I seem to be missing all my amendments.
If somebody could bring Senator Morrison a copy of the amendment. Members, you have it in your packet. This is an author's amendment. Senator Morrison moves the A1 amendment. All those in favor, please signify by saying aye. Aye.
Aye.
Any opposed? The amendment is adopted. And we have, I show Jay Desai, and I apologize if I said that incorrectly, but please come forward, and Shalini Colasingham. Welcome to the committee, please. Please go ahead and state your name for the record and begin your testimony.
Certainly. Shalini Colasingham.
And you need to speak really closely to the microphone and so we can hear you. Thank you.
Sure. So I'm Shalini Colasingham. So Madam Chair and members of the committee, thank you for letting me speak in support of this bill to modernize the operation of our state's central cancer registry. My name is Dr. Shalini Colasingham, as I pointed out. I'm a professor of epidemiology in the School of Public Health, and more importantly, I'm a member of the Masonic Cancer Center. In these roles, I often work with cancer registry data, and so I'm very familiar with their operation as well as how important they are to public health and science, and especially for people in our state. As I mentioned, this bill is about modernizing the Minnesota Cancer Reporting System. So the original legislation had provisions which probably made sense at the time, but at this point have come to be counterproductive. Nearly all cancer registries in the U.S. operate as this bill proposes. What that means is that Minnesota is now an extreme outlier compared to our other states. And those states, in fact, include North Dakota, South Dakota, Wisconsin, and Missouri. So we're an outlier even within the Midwest. The first provision allows MCRS to share patient information with other states and the federal government. Reciprocal data sharing is critical to ensure that patients are only counted once. So this really speaks to the accuracy of the data that we work with. So in essence, if someone is in Minnesota, but they're diagnosed in Wisconsin, they'll be counted in Wisconsin. We won't know that, and we will undercount the cancers that are occurring in our own state. So to that end, data sharing is so important, in fact, that the National Program of Cancer Registries, which is administered by the Centers for Disease Control, requires it. So as such, we as a state are in danger of losing not just grants from them, but in fact are probably ineligible for any more. What I should point out, though, is that anyone who receives Minnesota patient data, they're required to treat this data the same way as using the same protections as anyone who uses it locally. So the other provision changes the way that patients may be contacted to inform them about research projects. So right now, what we have to do is we have to contact the patient's oncologist and ask them for permission to contact the patient. So as you can imagine, with oncologists, it's difficult to reach them. That's assuming they even respond. And more importantly, if you were to step back and think about it, there's something paternalistic about this. This is an outdated way to actually have to ask a patient whether they want to be involved in research. And some of these might be clinical trials where they can potentially benefit. So having this additional step is preventing us from directly contacting these patients and asking them whether they would want to be in a study. So most states, I should point out, have eliminated this provision for physician permission to contact. And as a result, their cancer research has been greatly enabled. The Masonic Cancer Center is a nationally recognized cancer center. The work we do helps to identify what puts Minnesota residents at risk for cancer, how to improve their life expectancy, and the quality of life once they are diagnosed with cancer. But our ability to do this as researchers, it depends on having timely and accurate data, and that's what's being compromised right now. So I hope you will agree to pass this important bill to modernize our state's cancer registry, bring its operation, importantly, into alignment with that of other states' registry, including the ones that are surrounding us, and importantly, help us better serve Minnesotans. Thank you.
Thank you very much for your testimony. Did you wish to provide testimony, or are you here or more as a Senator Morrison?
Chief question answerer, Madam
Okay.
Chair.
Okay. Thank you. Members, any questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Morrison, I did give you a little warning that I would be asking some questions today. My concerns with this bill is patient privacy and family privacy, because if we look in the bill, it actually pulls in not just the patient, but also the relatives of said patient. Me being a family member of someone who's passed away from cancer, my grandmother who had both breast cancer and then it spread into Mets and bone cancer, and I watched a very healthy woman turn into a 40-pound woman in a very short amount of time. She was open. She wanted cancer research to be very good. She was willing to sacrifice everything she had for cancer research. My concern here is that it doesn't just take away the privacy rights of her, it takes away the privacy rights of the patient's family as well. And so for that reason, what information would be included in this registry, being that it lists the ability to reach out to families of patients?
Senator Morrison or a testifier? And please state your name for the record, and then you can answer the question.
My name is Jay Desai. I am with the Minnesota Department of Health, and I'm the director of the Minnesota Cancer Reporting System. And Senator Leske, in response to that, what currently happens, there isn't anything in there that I'm aware of that says specifically that you reach out to the family. But the way that this particular provision is that you would notify the provider before you contact the patient, or at the same time that you contact the patient. But just to walk you through the process, this is in regard to doing research studies or epidemiologic investigations. And the process for that is, first, if there is a study that's being proposed, it has to go through its institutional review board for whatever the major institution is first, before it comes to us. And then when it comes to us, we do an internal peer review to make sure that the study as proposed is appropriate for the Minnesota cancer reporting data. After that, we send it out to an advisory group of peer reviewers who review it again to make sure that it meets all the criteria of a study that's appropriate for the cancer registry, as well as meeting the different human subjects and data privacy laws that are in place to protect our citizens. And so after going through those steps, it is at that point that if it makes it through the approval of those, that we as the reporting system can reach out to that patient. We make sure that we go through the process to make sure that they're alive before we start sending things out. So it's only once we know that they're still alive that we will reach out with a letter to let them know about a potential research opportunity that they can choose to participate in or not. They don't have to pay attention to the letter. They don't have to pay attention to the information that they get sent. But if they want to, they have the choice to do that, and they can consent to participate.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, that brings up some more follow-up questions. Follow-up questions that I'd like to follow up with. I don't have an amendment created, but I do want to discuss that. I think it is up to the patient as to whether any of this information would be shared with the registry. So in theory, we should have wording in here that says if the patient gives their expressed written consent prior to the sharing of that information. So then you don't have to go back and ask their permission afterwards because you already know whether or not they're okay with that information.
Mr. Desai?
Yes, Senator Leske, what you're talking about is not what's explicitly in these amendments. It is something that is a bigger issue about doing public health surveillance for reportable diseases, right? In Minnesota, cancer is a reportable disease. And it's really important that we try and have as complete and accurate data as we can for all of Minnesotans and also throughout the country, so we can better, as Dr.
You can say Shalini.
Shalini says, that it's really, we need to have complete and accurate information so that we can take a look at what's happening, particularly with rare conditions, what trends are happening in Minnesota, what trends are happening nationally for different kinds of cancers. There's over 200 different kinds of cancers. And so it's one of the requirements is to have 95% accuracy at the national level. And so right now, the current provisions for the cancer registry are that we're able to collect that information in the interest of the public health so that we can take a look at what's happening, so that we can potentially do studies, so that we can investigate if there are cancer concerns. If we don't have that, then we would not be able to do any of those kinds of activities or responsibilities that we have to do as public health.
Madam Chair?
Senator Morrison?
Dr. Shalini wanted to add something as well.
Yeah, I just wanted to add a couple of things. The first thing is that for relatives, if you think about the definition of it, for children, for pediatric cancer cases, we would need to be contacting their parent. So we couldn't do that, right, if we were directly to have to contact the patient themselves. And then to Mr. Desai's comment about and to speak to the notion that you raised about research, one of the things that's critical is that if you think of a rare cancer, which a lot of pediatric cancers tend to be, the only way that we can study them is if we pool data from across the country. Some of these are so rare that we need those numbers in order to be able to identify any risk factors. So if we cannot contribute to the national data system, we are not only undercounting what's going on in our state, but we're not able to study what's putting these children at risk or what's putting people with these rare cancers at risk and how we might intervene.
Senator Liskey?
Thank you, Madam Chair. Madam Chair, my concern with this bill is it's taking public health and superseding a patient's rights to privacy. So when we read through this bill, again, we are saying that the public health supersedes the patient's right to their privacy. And so my concern is, what if that patient doesn't want to be studied? What if that patient doesn't want to be included in any of these studies? The fact that you're not allowing that is my concern.
Madam Chair, I would say that there are, Senator Liskey, I would say that there are protections in place for those patients, but I'll let the experts explain further.
Yes,
Mr.
Senator
Desai.
Leskey, as I had mentioned earlier, for a patient to be part of that kind of research study, they do have to provide consent.
Yeah, so you cannot participate in a study unless you provide consent, and hence the role of the parent. So the parent consents for the child, depending on the age. So they absolutely have a right to turn down the participation in that study. And even if they consent to participate in a study, they can withdraw that consent at any point with no repercussions, and that is very clearly spelled out in the consent forms that they sign.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, again, Senator Morrison, testimony here. The issue is you're, again, taking their information, applying it to a registry. Yes, they don't have to apply for the research program, but you are still broadcasting this to the federal government as to what type of cancer they have, who they are, where they live, where they're possibly being treated. All of that information is now getting submitted to the federal government, and they have not signed consent to that information being spread across the federal government, across other states, because now other states have access to the registry. That's my concern.
Senator Morrison.
Madam Chair, Senator Liskey, I sense I'm not going to convince you otherwise, but I guess I take issue with the word broadcast. That's really not what's happening in these cases. This is about studying cancer to benefit all of us, and particularly the example of pediatric cancers that tend to be very rare. I don't know if you want to add anything, Mr. Desai.
Yes,
Mr.
thank you.
Desai.
Senator Leskey, just to be clear, the data that comes into the Minnesota Cancer Reporting System, part of this bill, what it does is it actually says very clearly that any data shared to the national registries does not include name, does not include birthday, does not include social security number, does not include address, does not include telephone number, does not include any of those kinds of identifiers. So the information that gets submitted annually is de-identified information. So that does not get shared outside of the Minnesota Cancer Registry to national entities. And that is the same for any state-based cancer reporting system. So when we share some of that information to, say, our neighbors, for Wisconsin residents who have been diagnosed in Minnesota so they can have that information, they need it for process of deduplicating, make sure they're not counting people twice, but they keep it within their system. Then when they send it to the national registries, they also do not send any of those identifiable information. And then on top of that, we have been a registry since 1988, so 35 years now, and there's not been a single incident of any kind of data breach that would hinder someone's data privacy.
Senator Liskey.
Thank you, Madam Chair. Again, I think honestly I'd be on board with this bill if all we had to add was with consent. And in all honesty, that would be put me on 100% on board with having this information in a registry, again, as long as it's at the patient's consent. So if there's a consent up front, I'm all on board with what we're talking about. Does that make sense?
Yes, I understand. Thank you.
Senator Hoffman.
Thank you. So there's when you look at reportable diseases, the CDC, are you tracking off your MED, whatever, MEDSS, I think is the med electronic surveillance system that happens. The CDC sets their list, and each state has to set their list of reportable. I'm having a hard time wrapping my hands around because to the point about data privacy, right? I'm all for sharing medical information as long as it's medically necessary, right? But we as parents, and I'm a parent, right? And I understand that privacy piece, it's because it's personal at that point, and I don't think you answered the question other than you got a consent form that's signed. But I guess that led me to really ask the question, are we creating our own list of reportable diseases in Minnesota from the department standpoint, or are you going specifically off of what the CDCs and the National Institutes of Health are saying that we should be doing regarding reportable diseases?
Mr. Desai.
Yes, Senator Hoffman, as you know, the Cancer Registry was established back in 1988, and so at that time, did I say it right?
Madam Chair, just, I guess, was it established in Minnesota or was it established in?
In Minnesota, we established a registry in
To my point, Madam Chair, so this is a
Senator
state.
Hoffman.
Thank you, Madam Chair. This is a state indication, not a
But
national.
every state
Mr. Desai.
has a cancer reporting system. And we follow national guidelines and recommendations.
Okay. Thank you. Any other questions? Senator Radke?
Thank you, Madam Chair. And we've had a fair number of questions concerning the data and the security, and you're telling us that there is, but we also have people telling us there isn't. And written consent would seem to be something so simple to make this thing legit and to make sure that there's comfort from all involved. And because of that, I would like to offer an oral amendment, and we've got two spots on line 1.20 and on line 2.3. They both start a paragraph, and on 1.20, after the A, insert if the patient gives their expressed written consent, and the same after the B on page 2.3. It just puts it into statute that there is written consent, and then there would be comfort with what's being discussed.
Before we go on, I do want to say that this bill is going to be referred to judiciary. I think they have more of a skill set to address this question, because I'm not clear that patients haven't already given their consent. The data that is in the cancer registry, the research protections for patients, that's defined in the paragraph subdivision 1, correct? And
Yes, Madam Chair.
And the patient protections are defined, that's the data collection part of this. So after that, when we start talking about transfers of information, it relates to data that's already gone through the patient, the research protection process. And part of the research protection process is to collect consent for participation.
Madam Chair, you did
Senator
a much
Morrison.
better job of explaining it than I did.
So, Senator Radke, I guess what I'm gathering is that once you get to subdivision 2, that the part about patient consent has already been performed before getting to that. And then, the other things that happen. Senator Mann, did you have a?
Yeah, thank you, Madam Chair. You're absolutely correct, but also when you get to the second page, 2.3, we're talking about completely de-identified data, and I can't recall of any other medical database that we need explicit patient consent to provide de-identified data for data collection and research purposes. So that would be kind of unprecedented.
Senator Radke, did you have more questions?
I don't have any more questions because that was the big one, and I don't still have any comfort, but I guess if it's going to judiciary, we can tee them up and they can dig into it because that's their area of expertise. But, I have people with concerns, and with that, I have concerns, and I just want to make sure it's right. And to me, getting consent would be such a small issue. I mean, when they check into the facility for care, that would be part of the registration or the check-in. It doesn't seem to be an obstacle, but at that point, then the sharing of data has been confirmed with the patient, rather than the what-ifs that seem to be out there.
I was alerted that Twyla Brace wished to testify, and so I want to make sure that I provide time, because I wasn't aware, and I apologize for not having it come up when the other testifiers had finished.
Madam Chair, I'm certain that the timing must be perfect. Twyla Bray, Citizens Council for Health Freedom. And I just want to start out by saying that we appreciate the comments of these three gentlemen over here, and we actually believe that this is the place to do privacy protections. This is the Healthcare Policy Committee. This is talking about patients and how they feel in the exam room and at the hospital, and whether they know that their private information is going to be sent elsewhere without them. Indeed, there is no consent provisions. It's very clear that there's no consent provisions before it actually gets into the registry. The hospitals, the clinics are required to send this, and there is no consent provisions whatsoever. And so and when you talk about this, the part of the bill on page 1.17, 1.18, when it says research protections for patients will be consistent with this particular section and with the Code of Federal Regulations. So that's the common rule for federal regulations, the Federal Common Rule. The Federal Common Rule has 4 waivers allowed that IRBs are allowed to give waivers to consent requirements, including that the IRB, the members of the IRB believe that there's minimal risk. So the IRB gets to decide what's minimal risk and the patients do not. But there's additional exceptions and there's additional exemptions. So the federal rule on research actually has a lot of loopholes, as it were, to patient consent. So I think that's an important thing to remember. And we agree that there should be consent before it is given to the federal government. I do have a quote here from the National Committee on Vital and Health Statistics, and they said, even data properly de-identified under the privacy rule may carry with it some private information and therefore poses some risk of re-identification, a risk that grows into the future as new data sets are released and as data sets are combined. And so a little bit to what was actually said about, this whole idea of consent for research. The fact of the matter is there's no consent for surveillance. We've always opposed the fact that this system has been set up against the 10th, not the 10th Amendment, the Section 10 of the Minnesota Constitution, which protects people from warrantless searches and seizures by the government. This is clearly private data that is being taken without their consent. And so the other thing that I would say is Mr. Desai, I believe it was, said that the Minnesota Registry has been in effect since 1988. And he said, we've had no incidents of a data breach. But I believe that patients, if they understood that their data was being taken without their consent, some people will be all for research, right? But just the fact that the government takes their data and tracks them throughout, and now we'll share it with other states. We've been the only one who has actually protected the privacy within this state and shares it with the government, which can then re-identify it, because as the federal government itself says, it can be re-identified. This is where patient consent should happen, and we should continue to protect it within Minnesota, which has some of the strongest privacy laws in the nation. So I encourage that amendment, and thank you for hearing my testimony.
Thank you. Members, this topic is, I think, best discussed more in depth in the Judiciary Committee, so I would like to, rather than trying to amend something here, I think they should have the opportunity to receive the bill and discuss it. Are there any other questions or comments? Senator Morrison, any?
Thank you, Madam Chair. Thank you for the conversation. This is an important bill that has been in the works for many years to help Minnesota get up to speed so that we can best research, treat, and prevent cancer. Thanks for the consideration.
Thank you. And Senator Morrison, your motion to move that Senate File 2341 as amended be recommended to pass and be referred to the Committee on Judiciary and Public Safety. Is that your motion?
That is my motion, Madam Chair.
Members, all those in favor, please signify by saying aye.
Aye.
Any opposed? No. The motion does prevail. The bill, Senate File 2341, as amended, is passed and referred to the Committee on Judiciary and Public Safety. Senator Morrison, do you have the next one, which is at 2338?
Thank you, Madam Chair. Yes, I have Senate File 2338, and I believe I have an author's amendment.
Yes.
The A1.
Members, Senator Morrison has the A1 amendment to Senate File 2338. This is an author's amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Morrison.
Thank you, Madam Chair. Senate File 2338 is about lead, and this is another opportunity to remind ourselves that there is no safe level of lead in drinking water. Clear and transparent definitions are imperative for being able to use service line inventories to identify and remove sources of lead that can get into water. EPA's lead and copper rule revision definition of a lead service line excludes lead gooseneck, pigtails, and other connectors from its definition, but requires that these connectors be removed when found. Including them in the state definition of lead service line allows systems to inventory and seek funding to remove them as part of an asset management approach rather than a haphazard as they are found approach. That is the bill, Madam Chair and members.
Thank you, Senator Morrison. I see two people listed as testifiers. Oh, yes. We have two testifiers listed, Chad Kolstad and Dr. Stephanie Yandel. Welcome to the committee, and please.
Madam Chair, this testifier is here just to assist with questions.
Oh, okay. All right, members, any questions?
Madam Chair.
Senator Hoffman.
Going to the floor with
No, this is going to be laid over.
Bill, can we go to the floor?
I'm sorry.
Okay, thank you.
Sorry.
Senator Etke.
Thank you, Madam Chair. And Senator Morrison, I was trying to read some of this really quick. Is this just an inventory for lead pipes, or is this creating a service and where there'd be an expense to it?
Senator Morrison.
Madam Chair, Senator Udke, this is just clarifying language on definitions.
Okay, thank you.
Any other questions? Oh, seeing no other questions, any other comments, Senator Morrison?
Please support the bill, Madam Chair and members.
Thank you.
Thanks for your help.
And Senate File 2338 is laid over.
As amended. Sorry.
Thank you. Next, you have one more, 2340, Senate File 2340.
Thank you, Madam Chair. Senate File 2340 is another opportunity to remind ourselves that there is no safe level of lead. Lead exposure can cause adverse health effects in almost every organ system in the human body. Ongoing exposures to lead in the environment present a health risk to people nationwide. This is especially true in communities overburdened by pollution, which are disproportionately communities of color and low-income communities. The changes in this bill will allow MDH to administer EPA's renovation, repair, and paint program. Certain statutory provisions governing renovation and licensing for a certified renovation firm are inconsistent with EPA RRP regulations. For Minnesota to self-certify and receive authorization from EPA to enforce the RRP program, Minnesota statutes need to align with EPA regulatory provisions. And Madam Chair, I think I forgot to move my A1 amendment, didn't I?
Thank you, Senator Morrison. Yes, there is an A1 amendment. Senator Morrison moves the A1 amendment, author's amendment. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? The amendment is adopted. Any other comments about the bill? Or I show Mary Navarra and Bruce Lang. Are they here to provide any additional testimony, or are they here for questions?
You guys want to?
Madam Chair, members of the committee, my name is Jackie Kavanaugh. I'll be available to answer questions on the bill. As Senator Morrison said, the amendments in this bill make conforming changes with federal EPA regulations so that the department can adopt rules that the legislature has directed us to do, regulating the renovation of pre-1978 properties. The bill also makes other amendments, clarifying and housekeeping changes to MDH's residential lead abatement program. And I can stand for questions.
Members, any questions? Senator Abler.
Thanks, Madam Chair. I felt like I was disappointing you not having questions. Madam Chair, Senator Morrison, I like the whole idea where you're going with all this lead business, and perhaps I'll sign on even as a co-author in general, but is there, I don't see any builders flooding the room to say this is going to make life impossible. Is this just common, and is it a burden on anybody? Do you have any opponents or anything like that?
Senator Morrison.
Madam Chair, Senator Abler, not that I am aware of. This is primarily clarifying language for MDH.
All right.
Senator Abler.
Well, just making sure, you know, I think, because there's the, any way we can reduce lead, it's better. It just doesn't go away, and people deserve a shot at not having lead. Thank you.
Any other questions? Senator Morrison, this is another bill that we will be laying over, and so Senate File 2340 is laid over.
As amended.
As Senate File 2340 as amended is laid over.
Thank you, Madam Chair.
And now we are going to switch back, and I'm going to present Senate File 652 so that we can accommodate a testifier here, so I can better explain the bill.
Senator Wiklund.
Thank you, Madam Chair. This is Senate File 652, and it has to do with modifying MFIP general citizenship requirements. And since we have an expert here who can testify more specifically about the intent and what the bill accomplishes, I will turn this over to my testifier, Jessica Webster.
Ms. Webster, please introduce yourself and proceed.
Thank you, Madam Chair, members of the committee. Thank you for the opportunity to testify. My name is Jessica Webster. I'm a staff attorney with Legal Aid here in strong support of Senate File 652. And we really see this as more of a technical cleanup of MFIP eligibility. So if you look at the bill, in Section 1, MFIP law, current MFIP law, says to be eligible for MFIP, a member of the assistance unit must be a citizen, a qualified non-citizen, or a non-citizen who is otherwise residing lawfully or legally. Right now, though, if you then go to subdivision 1D, there's language here that actually excludes parents who have U visas. U visas are for victims of crime, and T visas, people who are victims of trafficking. So we're excluding two categories of parents who are legally residing in the United States. They have a lawful status. And the folks who have U visas and T visas, these are folks who, they are victims of a very violent and significant crime. They're cooperating with law enforcement, oftentimes cooperating with prosecution. So they're working to make our community safer, but when they bravely step up to do that, they sometimes lose their housing, their transportation, their community support networks. So Legal Aid believes this just makes sense to make sure that folks who are legally residing in the United States, who have lawful status, are eligible for MFIP. These are parents with kids. It's a very small number of people. Thank you for the opportunity to testify.
Thank you, Ms. Webster. Members, questions? Senator Ruckey.
Thank you, Madam Chair. And if I could, when you referred to the, you had us start out with who is eligible, and did you say I didn't hear you right. Is that when you jumped to the new language where the V is added, and that's what you were referring to? Because that was going to be that A-S and V. That's the part that tied it together then.
Madam Chair, Senator Utke, so yes, so if you look at subdivision 1D, you see United States Code Title 8, Section 1101A15. Right now, it's A through S, not T visas and U visas, and V. So it keeps these statuses intact still as ineligible, but it makes T visas and U visas eligible for MFIP.
Thank you.
Other questions? Seeing none? Any final words, Senator?
No, I think that the explanation is clear, and I believe we were laying this bill over. It does have a fiscal impact, so we've requested a fiscal note.
The fiscal note is here.
Oh, okay.
So we're just going to take a look at that. Otherwise, we will lay it
I
over.
didn't bring it over, I'm sorry.
okay.
So I don't know if anybody has questions about it.
Seeing no questions, we will lay it over.
Thank you. I appreciate it. Madam Chair, do we want to do the other two bills that I have, and then?
Go ahead, Senator Wiklund. On 2212 members.
Madam Chair, I do have an amendment for 2212, the A1 amendment.
Is this an author's amendment?
Yes. It is. It removes a section, or removes a subdivision, basically at the lines 4.15.
Okay, Senator has an author's amendment. All those in favor say aye.
Aye.
All those opposed? The amendment is adopted. Senator, to your bill as amended.
Members, this is one of MDH's policy bills, and also we plan to use this bill as a vehicle to put together an omnibus MDH policy bill. And so several of the bills that we've laid over tonight, we will bring back in a way that we can combine into one bill. And I did not bring over the testifier list. Is there someone available in particular? If you'd be willing to just give comments about the bill, I'd appreciate it.
Please introduce yourself and proceed.
Good. Thank you, Madam Chair. Good evening, committee. My name is Molly Crawford. I'm the State Registrar with the Office of Vital Records at the Minnesota Department of Health. This bill is a technical change to existing law. It amends two sections of law to streamline the language to reflect current procedures and updated technology related to fetal death reporting, fetal death records, and the issuance of certificates of birth resulting in stillbirth. Our hope is that it clarifies the language and reduces confusion both for the facilities involved and the parents who receive the certificates. It removes obsolete language and eliminates steps that are no longer necessary for parents to take in requesting a certificate of birth resulting in stillbirth.
Thank you, Ms. Crawford. Members' questions? Senator Abler.
Well, thank you, and I'm glad it's technical. I just remember some of the hearings we had with parents of stillborn children and how compelling some of that was. And so this isn't going to change anything for them. It's not easier or harder, it's just cleaned up, is that?
Ms. Crawford.
Madam Chair, I do think the language allows MDH to treat fetal death records in a similar manner to birth records and death records, in that the language will allow both parents, either parent, to request a correction or an amendment to the fetal death record. Current law only allows the mother who delivers.
Senator Abler.
I just learned something every day. And just a comment, and saved you 20 minutes by taking out subdivision 2. So thank you very much. And that could just stay gone maybe, but thank you.
Members,
Appreciate
other
it.
questions? Seeing none, we will lay over Senate File 2212. Are we going on? Senator Wiklund to Senate File 2048.
Thank you, Madam Chair. Senate File 2048 is also an MDH Policy Bill. This bill has to do with expanding third-party transport of medical cannabis. Current statute limits the transportation of medical cannabis and medical cannabis products to the 2 registered manufacturers. This is problematic for the following reasons. One, MDH inspectors and other Office of Medical Cannabis staff do not currently have the authority to transport plant or products. This was problematic during the E-Valley vaping crisis when we needed to transport product to a lab to test for and rule out the presence of potential dangerous additives in vaping cartridges, and continues to be a barrier for effective compliance and enforcement efforts of the agency. MDH currently cannot sample or transport product under current law. Secondly, with the addition of dried raw cannabis to the medical program, manufacturers may like to hire security firms for some transports. Current law does not allow for this. Other states have seen high incidents of robbery of product and cash of non-secure cannabis transport, and allowing for secure transport would provide an added layer of safety. The current statute severely limits the transportation of medical cannabis products to only the 2 manufacturers. When conducting state inspections and investigations, there may be instances when MDH needs to secure product as part of its compliance efforts. Additionally, with the addition of dried raw cannabis, the program has seen a large increase in enrollees and now serves over 40,000 patients. Multiple transportation options are needed in order to adequately serve patients. MDH has been in regular conversation with medical cannabis manufacturers, patient advocacy groups, and other stakeholders regarding this topic. And I'm not sure if there is an MDH person here designated to answer questions, but perhaps.
Looks like we have someone coming down. And it also looks like you have an A1 amendment if you want to move that.
I'm not aware of that.
I don't think we have an amendment.
Okay, I don't.
No?
This was a department request to match up with the House.
Oh, okay. So maybe they already adopted in the House.
I don't think that they did. She said yes, but now she's saying, okay, if we don't vote it, it's not adopted. That's what was given to me, and I just didn't make it up myself.
Madam Chair. I think it's a technical amendment. We can have council explain it if you want.
Go ahead, if you.
Madam Chair and Senator Wiklund, the amendment deletes the existing paragraphs D and E and then puts them into one paragraph. The way the bill was written, paragraph E looks like it would require 2 MDEs in all transports instead of just the MDE transports, so it puts it all in one paragraph.
Thank you, that clarifies. Then I guess I would like to move forward with the author's amendment.
Okay. All those in favor of the A1 author's amendment say aye.
Aye.
All those opposed? The amendment is adopted. Did you want to testify or just answer questions?
Just questions.
Members, any questions? Senator Uckey.
Thank you, Madam Chair. And just verifying, you got medical cannabis manufacturer may contract with a third party, but then we're also talking about the department. Is the department a third party, or is these two separate things? The manufacturer could contract with a transportation company or whatever to move their product.
Please introduce yourself.
Good evening. I'm Chris Thokus. I'm the director of the Medical Cannabis Program at the Minnesota Department of Health. Madam Chair, Senator Uckey, these are two separate things. One is the need for the staff at the Department of Health and the Office of Medical Cannabis to be able to transport product in the course of compliance and enforcement efforts. The other is a need for manufacturers to potentially contract with a third party to provide secure transportation for product.
Senator Uckey.
Thank you, Madam Chair. And the fact that we're talking about the cannabis manufacturer, is this because there are those out there that are wanting to get into the business? I mean, our statute and everything currently today it's all built around two manufacturers, and they're located here in the metro. But there are at least two locations that I know of outstate that are building growing facilities and plan to go into the medical marijuana, medical cannabis. Is this to accommodate that?
Ms. Thokus.
Madam Chair, Senator Uckey, no, this is intended for the medical cannabis manufacturers are restricted to one cultivation and one processing facility, which are both located in the metro or slightly outside of the metro area. And there are 16 dispensaries that are allowed under current law, and it's about transporting product from their cultivation and processing facilities out to the corners of the state where the dispensaries are.
Okay, so
Senator Uckey.
thank you, Madam Chair. It's built around our current system of medical cannabis, so good, thank you.
Members, other questions? Seeing none, any final thoughts?
Madam Chair, no, I think this is just to clarify and the policy and to make it a little more possible for options for the manufacturers.
Super. With that, we will lay Senate File 2048 over.
Thank you. I'm sorry about the confusion. Sorry. Senator Kupek. Now we have Senate File 2800.
Yes, and I do have an author's amendment to begin with. A1 should be in your packet.
Members, Senate File 2800, there's the A1 amendment that's in your packet. This is an author's amendment.
Okay, Madam Chair.
Oh, Senator Abler.
I have an amendment to the amendment that we worked out.
Oh.
Is this an appropriate time for that?
Well,
I think it may be.
If it's something, yes, can we have the amendment to the amendment distributed, please?
Yeah, and I can explain it. Actually,
Senator Abler.
So the amendment cleans up some of the language to handle, actually it'll make testimony a lot shorter tonight. So that's the author's amendment. And then mine clarifies, if you look at the original bill, it takes away a group that's advocates for the developmentally disabled. And so this just keeps the count the same, but separates it into two consumers and then that language stays, and then we just separate out the developmentally disabled consumer. So, and Senator Kupek said he was okay with it. I think it makes the bill better, so, without adding any more people.
Senator Kupek?
Sure, I just wasn't sure if it was an amendment to the amendment or an amendment to the actual bill, but either way we do it,
So we'd vote on that first.
Mr. Monahan, are we should we proceed as an amendment to the A1 amendment? Okay. Senator Abler offers the A3 amendment to the A1 amendment. Members, are you clear on the language? All those in favor, please signify by saying aye.
Aye.
Any opposed?
Thank you.
Members, the A3 amendment to the A1 amendment is adopted. Senator Kupek,
Do we still need to do then the A1?
we need to move the A1 amendment now. And members, all those in favor of the A1 amendment as amended, please signify by saying aye. Aye. Any opposed? The A1 amendment as amended is adopted. And Senator Kupek, do you want to go back to describing your bill?
Sure, absolutely, and thank you for that. And just to go back to the amendment, after some discussions, there was the dentist in there, and then there were not there, so we added the dentist back in, and we also added an oral health professional, so it did expand the board a little bit, but that just made everybody, I think, on the same page with this bill. So the Rural Health Advisory Committee, established body whose members are appointed by the governor to advise the Commissioner of Health and other agencies on rural health based on RHC membership recommendations. This proposal adds members that can bring important perspectives to the board. The bill adds a member of a tribal nation. It adds a representative of local health and community health boards. It also adds a health professional or advocate working with people with mental illness. It does add a representative of a community organization working with or experiencing health disparities. And then also it adds a member with experience in economic development.
Members, any questions about the bill? Senator Abler?
Is this being laid over?
No, Senator Abler, this one is being, we need to pass and send on to state government.
All right. Well, just,
Senator Abler?
yeah, so I don't know if it goes on its own or not, and I know Senator Kupek likes the Senate way. I think we've improved upon this proposal so that, I don't know what happens in negotiations later, but I hope that this just thoughtful Senate language can prevail. Thank you.
Thank you. Any other questions? Senator Mann?
Thank you, Madam Chair. Senator Kupek, just what was the impetus for changing the council?
I could bring up somebody
Do
from.
we have someone from the department?
From the department here to explain. But as far as I know on the first part, I think there was, I know on the first part, I can explain the part with the dentist and the oral, that I know pretty well. So I know that the department had said they had trouble at times finding a dentist that could actually make the council. And so then they were going to expand to an oral health, just professional. But people from the Dental Association also wanted to make sure they were included. So that's why that part got fixed. That, and then if you want to, you can add to the others why they were added.
Welcome to the committee. Please state your name and answer the question.
Thank you. I'm Zora Radosevich. I'm the Director of the Office of Rural Health and Primary Care in the Minnesota Department of Health. Madam Chair, the Rural Health Committee had, the issue of dealing with rural health is just such a broad issue, and thought it would be really important to add like economic development and just broaden the discussions that are happening at the committee level. They take on the whole range of issues related to rural health, and those are, they're just broader than the health professionals that are included. And so I thought it would be a good way to expand the membership and bring those important voices in. And then as population health and community health has just become so much a part of how we need to deal with health, especially in rural areas, but to combine both the private sector health with public sector health, and just keep all of that as part of the discussion when addressing these issues.
Thank you. Senator Mann, did that answer your question? Okay. Any other questions or Senator Abler?
And so, I'm sorry I didn't catch your name, but these changes seem like good, sensible ones to me. Is the department comfortable with those?
You're referring to the changes that we made through the amendments?
Just cleaning up
Madam Chair,
dentist and so on.
Senator, the recommendation from the oral health report was to add an oral health professional. So that was why the bill was drafted the way it was originally.
Okay. Well, Madam
Senator Abler.
It wasn't to
don't-
be representative of every single health profession.
Right.
Was that your question?
Well, we made a few changes we thought made it consistent with your clear intent here. So I hope that you're comfortable having a dentist and an oral health professional. And I don't need to talk very long about it, but we can't find any dentists who want to take medical assistance, folks, and I'm sure particularly in greater Minnesota. And so it seems like if you're trying to draw them in, you want to include them, so maybe you can find ways to entice them to be a part of our service system. That was my thinking on it. So.
Thank you, Madam Chair. Senator, that was the reason why we had gone with an oral health professional, and that was the reason that the report had suggested that, because so much of addressing oral health in rural Minnesota includes those allied health professions, the dental therapists and collaborative practice dental hygienists, beyond that, the dentists, because of the issue of dealing with oral health. We really do need to broaden that.
Yeah.
And if bringing them on the committee is going to help with that, I think that's great.
Yeah. So, I mean,
Senator
I hope you're saying you don't mind them being on there, because I think it strengthens your bill. So, thank you. I'm putting you on the spot. I realize we just trapped you into this. So, thank you very much.
Any other questions or comments? Senator Kupek, any other final words? I think these are, I would say, I also agree that these are changes that I think make the committee stronger, and I had some concerns about the items as well, so I
Sure.
appreciate your making the changes.
I think so too, Madam Chair. I think if we can bring more people into the discussion, particularly in rural areas, about healthcare, I think that's important.
Seeing no other questions, Senator Kupek, your motion would be to recommend that Senate File 2800 be as amended, be recommended to pass and be referred to the Committee on State and Local Government and Veterans.
I will make that recommendation.
Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does pass, and Senate File 2800 as amended has referred to the Committee on State and Local Government and Veterans. Thank you. And our last bill tonight is Senate File 2122. Senator Bolden. And Senator Bolden, you have an author's amendment?
I do, Madam Chair. I would move the A2 amendment, I believe.
Uh-oh. I have the A1. Is there an A2 that should be instead? Or is it? I don't know. Unless, in my packet, I have the A1, so I don't know, maybe if. Okay. If we could have copies made of the A2, then we will be able to distribute that. Is it something where you can tell us a little bit about the bill before we have that amendment in front of us?
Yes, Madam Chair, happy to do so. So this is an MDH Policy Bill. MDH licenses and regulates many types of healthcare facilities in Minnesota, including hospitals. There are approximately 143 licensed hospitals in Minnesota with a patient capacity of 16,465 beds. The current rules governing licensure, operations, and physical environment standards for hospitals in Minnesota were written and promulgated in 1955 and do not reflect the contemporary standards for acute care in the United States. In the absence of current requirements to the rules, MDH has been issuing waivers to enforce the updated requirements. The rules are so outdated, they also don't recognize many aspects of the physical environments of modern hospitals. Right now, if a hospital does not desire to follow the standard, they do not have to if it otherwise meets certain Minnesota rules as promulgated in 1955. So this bill proposes to adopt the 2022 edition of the Faculty Guideline Institute, or FGI, guidelines for design and construction of hospitals as the physical environment requirements for all licensed hospitals in the state. And the amendment was based on some feedback from the American Institute of Architects and just incorporated their recommendations and feedback.
Senator Bolden, we are consulting because apparently there is some desire to amend the bill with the A1 amendment and the A2 amendment. And the A1 amendment we have available to us. I don't know if you have it.
I do not have the A1 amendment, Madam Chair.
I don't know if somebody could. And can I ask if I'm sorry, I don't have your name written down here. Do you have information that could help us with this A1 amendment, or is there someone else from MDH that is knowledgeable about it so we can? We are receiving further information, so maybe we need to get that before we proceed. What I've learned is that the A2 is actually a delete everything amendment, so we need to have that first, and then my understanding is then we can amend it with the language of the A1 amendment, and council can help us do that. But to go further, I think we need the A2 amendment before us so that we can adopt that first. And I believe they are printing that. Give us a minute here to figure this out. Do members have any questions about the bill itself? And you can make it, okay. Yeah.
Lovely.
All right. Ms. Stengel, could you give us kind of a rundown on where we should go? If we have this delete all amendment, do we need to take action on the A1 amendment?
Madam Chair and members, the A2 is a delete everything amendment, so I think you'd want to, if you want to move an amendment, move the A2. The A1 amendment doesn't work with the A2 anymore, so we can't adopt that one. I think a lot of the A1 has been incorporated into the A2, so if we review it and there needs to be additional changes later, we can do another amendment as this moves forward.
And I believe we are going to lay this bill over, so we can address that if we find that the language isn't complete. So, members, let's take action. Senator Bolden moves the A2 amendment. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed? The A2 amendment is adopted. And to the testifier, did you have any comments or any additional information, or were you hoping to answer questions if we had them?
I can testify.
Okay. Please go ahead, state your name for the record and proceed.
Thank you, Madam Chair and members of the committee. My name is Bob Daler, and I'm the engineering manager in the Health Regulation Division at the Minnesota Department of Health. And one of the many jobs the engineers in our section do is they review all construction activity that takes place in licensed hospitals in the state. And so we do this by reviewing construction drawings and performing final construction inspections. And this bill essentially proposes to adopt the 2022 edition of the Facility Guideline Institute, the guidelines for design and construction of hospitals as the physical environment requirements for licensed hospitals in the state. I'll probably just stop there because I thought Senator Bolden did a great job kind of explaining, giving some other background information. So I'll just say I'm happy to answer any questions, and thanks for having me here tonight.
Thank you very much. Members, any questions about the bill? Senator Abler.
I'm kind of interested in the self-renewing nature of the standards. So do we do that anywhere else, where we just automatically take what somebody else says and just incorporate them in?
To the testifier, do you, please?
Yeah, Madam Chair and Senator, this language was kind of taken from the language from the assisted living licensure law, and the assisted living licensure law actually did the same thing that this does. It allows the updated editions of the guidelines to be adopted.
Yeah.
Senator Abler.
No, Madam Chair, it saves a lot of legislative time, is to keep whatever the new book comes out, you have to do it. And so does that mean that we just kind of accept whatever somebody else decides and we don't look at it with our Minnesota eyes? And that's the concern I have. I mean, there's some things that make sense that the feds tell us what to do too much anyway, or whatever group this is, and so we're just locking ourselves in. And I mean, I guess I'm not losing sleep over it, but why do we even have a legislature or a state if we're just going to do what the feds do? And you're free to comment if you like, sir.
Please proceed.
Madam Chair and Senator, I just lost my train of thought.
Oh,
I mean, Madam Chair.
Senator Bolden.
I would just point to line 1.18. It does talk about the commissioner reviewing the guidelines and determining if they would be updated, and then notifications to follow.
Oh.
Senator Abler.
That's better. And then, I haven't studied this topic well enough to be very dangerous, but I don't know how it is to build a hospital. But if you're going to add on a room, do some new construction or change of use or change occupancy, let me just ask about the new construction. I think people are used to having new construction conform. But can you talk about change of use or change of occupancy? It's on 1.14 and 1.15. If they change it from a certain kind of, use of a room to a different kind of use of a room, is this going to be one of those things that you have to pay $10,000 to change the flooring or something? Is that how it works?
Madam Chair and Senator, what happens with that is there are the specific rooms. Well, I guess I can go back a little bit and talk about the FGI. And we talk about building codes and fire codes and all those other types of codes that we have. They talk about how to build a building and make a building safe. What the FGI talks about is what the building looks like inside. So when somebody would come and say, we want to do a change of use from this storage room to an operating room, there's very specific requirements of what goes on into an operating room and what's in a storage room. So this just basically says if you're changing that use, then you need to meet the use of what's required in the FGI.
Yeah.
Senator Abler.
And I guess I'm just curious if there's any kind of reasonability test. And I don't know how you've worked at the Department of Health. I've been enjoying your company as a department for 24 years, and sometimes I'm wondering, like, really, that's what you are thinking makes sense? So is this going to go anywhere, Madam Chair, or is this just staying here?
Senator Abler, no, we're laying this bill over.
All right. The hospitals aren't here. It was posted, so I suppose they're watching this. So anyway, just if you can be nice to people that are making sense. We have a lot of old hospitals in greater Minnesota that are perfectly good, and you could change a use in a modest way, but now you have to make it meet this totally new, I don't even know what the old code is you're working off of, but it was perfectly fine. If you just did a few things, it'd be just as perfectly fine, but now it doesn't meet one of these stringent criteria based upon 2022 standards, which are far different from 1981 when they built it. So I just hope there's some way to be reasonable. Looks like you're being rescued by the boss there, so.
Ms. Timian.
Madam Chair, members of the committee, for the record, I'm Lisa Timian at the Department of Health. Senator Abler, yes, we have worked closely with the Hospital Association to make some updates to the language that they requested, as well as the Architects Association. So I think, to borrow a phrase from you, this is a nice piece in the valley.
Senator Abler.
Madam Chair, always good to get the boss at the table. So thank you. That's good. That's helpful to me. Thank you very much.
Thank you.
I'm all done.
Any other questions? Senator Edke.
Thank you, Madam Chair. And question about some of the details in here. And our testifier had commented on some of the things that went into this. And I noticed from the original bill to the delete all, I was concerned about the timelines where the hospitals, in the new language is date by which hospitals must comply shall be not sooner than 12 months. The old language said 6. Is the 12, is that consistent with what they were working under currently? The timelines, have they changed any in this process? Are we shortening them up? Just thinking that when they start a project, you can burn up a year or two pretty quick from the original design until you finally get out and start building and doing construction. And if this came along and there was a 6 or 12-month timeline, would that mess them up?
Madam Chair and Senator, we originally had the 6 months, and after discussions with the Minnesota Hospital Association, we did change that to 12. And the reason behind that is to give the designers time. So if they did start a project under design, it would allow them that time to finish that design and submit it to us for review before the newer edition is mandatory, essentially. So during that time frame, they would have the option to either use the current or whatever's new if something new is getting adopted.
Senator Edke.
Thank you, Madam Chair, and thank you. That's those numbers had changed, and I was wondering, and now they align with where everybody's got comfort, so thank you.
Any other questions or comments? Senator Bolden? Any other final comments?
This is a common sense bill, Madam Chair, and would encourage members' support.
Thank you. And Senate File 2122 will be laid over for. And I think we have completed our journey through all of these bills, and seeing no other work before the committee, we are adjourned.